It's my pleasure to introduce Dr. Francine Kaufman, who's going to be presenting medical grand rounds today. The esteemed Dr. Kaufman comes to us from the USC Keck School of Medicine, where she's a professor of pediatric endocrinology. She has been the past president of the American Diabetes Association, former chairperson of the National Diabetes Education Program, and the current chief medical officer of Senseonics. She's recently joined the Sansum Diabetes Research Institute as principal of scientific and medical affairs. Dr. Kaufman is a global authority as clinician and researcher in both type 1 and type 2 diabetes. She has published extensively on the genetics of type 1 diabetes, insulin pump therapy, and type 2 diabetes in the young. She has been very influential in the field of diabetes. She was a main researcher in the Today trial, chronicling the natural history of type 2 diabetes in obese adolescents. Today, Dr. Kaufman is going to share some new data and concepts on the screening and prevention of type 1 diabetes. So thank you, Dr. Kaufman, for coming.
Thank you. I appreciate that generous introduction. I would only wish my kids were here to hear it. So I am going to speak about the type 1 diabetes process, which we are now staging and attempting to interdict so that we can eventually prevent and perhaps cure type 1 diabetes. So my conflicts. So talk a little bit about the burden of type 1, how we're doing now, some of the natural history and staging. What we've learned from some of the really hallmark large NIH-funded trials, the reason for screening, the approach to screening and staging, and then a little bit about the first agent that has shown to have effectiveness, teplizumab or Tzield, and then I'm going to talk about Italy. So the burden of type 1 diabetes, and as a pediatric endocrinologist at Children's Hospital Los Angeles for, and I'm very proud of this, almost 50 years. When I started my clinic, we had 300 patients and 2 endocrinologists. We now have about 4,000 patients and 20 pediatric endocrinologists to meet the needs of our patient population. So type 1 diabetes, particularly in children, has been increasing, doubling every 20 years in the overall population and every 10 years in the young, particularly in children under the age of 5. Expected to reach 5 million people by 2050. And of course, half of type 1 diabetes is diagnosed in adulthood, often perhaps missed and misdiagnosed as type 2. There's still morbidity and mortality associated with it, particularly when glucose is not effectively managed, with a shortened life expectancy, acute complications of hypo and hyperglycemia, and then the long-term micro and macrovascular disorders associated with this disease. Large economic burden as well in an episode of diabetic ketoacidosis. And this is important because one of the reasons to screen is to prevent DKA at new onset is in excess of $30,000 per patient. So this is my favorite slide. Matter of fact, I'm thinking of making it into wallpaper. This is about the Type 1 Diabetes Exchange, which is a consortium across the country involving 33,000 patients or so with type 1 diabetes at a variety of centers, both academic and community-based, looking at what are the outcomes on a common data sheet. So if you come down, and I think I can control this, we look at a period of 2016 and 2017 in the orange, and then 2021 to 2022 in the blue. And across the bottom is age, and the y-axis is hemoglobin A1C. We can see that we are not at goal, which is less than 7% for an A1C, and If you're an ACE believer versus ADA, it's actually 6.5. I happen to work with this age group, children, adolescents, and young adults, and you can see we don't even get through adolescence till about the age of 30, when it becomes what we see throughout the adult time period. So less than optimal control of this disease, despite an increasing trend over time of the use of CGM, an increasing trend over time with the use of insulin pump. And then looking at these different colors, they represent the different racial and ethnic groups, and you could see that those of color actually have less access to diabetes technology. And as a result, their outcome as far as A1C is less than optimal. For a variety of reasons. Is there institutional racism affecting this? Is there some aspect of what the patient expects and wants to do themselves? Is there access and affordability issues? But when we come down here and look at non-Hispanic whites, non-Hispanic blacks, and Hispanics, and look at the difference in A1C in the prior time period and now, even now, although it has gotten better, it is still not to target and still showing racial ethnic disparities. So that gets us to what's the natural history of type 1 diabetes. And this natural history, which looks pretty simple on this slide, has taken decades to come to realize. And if you start at birth, somebody is born with either the genetic risk for type 1 diabetes or not. And then if they do have that genetic risk, there's a number of exposures that we think occur beginning in utero, perhaps very important in early life, including from birth to 1 or 2 years of age, that allow for the immune activation of the diabetes process, which is a very complex immunology involving an attack to the pancreatic beta cells. That immune activation, which may follow something that is ubiquitous for all children involving dietary exposure, perhaps viral exposure, then leads to an immune response that we can then see in stage 1 type 1 diabetes, which is now the presence of a normal blood sugar, but in the face of the development of more than two or more autoantibodies, suggesting this immunologic reaction. Stage 2 is a continuum now, abnormal glucose values, analogous to what we see in prediabetes for somebody with type 2 diabetes. And then progresses to clinical diabetes and obviously the persistence of the presence of autoantibodies. And then stage 4 is kind of the long-standing past the honeymoon, which many patients have. All honeymoons are worth keeping, and one of the goals of much of this is to prolong that honeymoon or remission period of type 1 diabetes. And then if we look at what's really going on, we can see that here is a normal islet. Here's now the immune infiltration, and the loss of the beta cell mass as we go from this genetic risk to the immune activation to stage 1, stage 2, and now stage 3 type 1 diabetes. And at the same time, normalization of the blood glucose until we get to stage 2, glucose values that are like prediabetes, and then stage 3 glucose values that reach the diabetic threshold. So lots of debate. If you want to come to some great debates, they are about, is there a primary defect of the beta cell, or is this really just an autoimmune response to a normal beta cell? Regardless, and perhaps maybe there's some element of both, maybe not all patients have the same endotype that gets them to type 1 diabetes, and we know these endotypes are quite different by what antibodies and what kind of titers, what HLA, what other immune markers can we see. And when we talk about type 1 diabetes, we're talking about a plethora of ways to get there, and endotyping of patients becomes more and more important. But when we look at the immunology, we want to induce and restore immune tolerance for the beta cell and reverse islet autoimmunity. When we look at the beta cell, we want to protect the beta cell mass, and we want to protect beta cell function to restore and prevent dysglycemia, the exogenous requirement for insulin, and the clinical manifestations and complications of diabetes. So these antibodies, and there's now 4 that can be measured, and these can be measured commercially, are against insulin itself, insulin autoantibodies, against glutamic acid decarboxylase, an enzyme on the cell surface of the beta cell called GAD antibodies, and islet antigen 2 that is exposed on the cell surface of the beta cell, IA2A, and then a zinc transporter that is on the surface of the beta cell as well. These can be detected in low but sufficient titers. Actually, these tests are easy to do in clinics, in labs, and even at home through kits that are available for people to test their own autoantibodies. 2 or more are highly predictive of the development of diabetes within a 10-year time frame, if not less. Usually, insulin autoantibodies are first, and then GAD, and then there's high conversion rates of these autoantibodies during childhood. So when we look at who is at risk for this, in the general population, about 0.3% of individuals have antibodies. Many of them have only one, which diminishes their risk of developing type 1 diabetes over time, but once there's 2 or more, there is a very, very high risk of the development of diabetes. Monozygotic twins with the same genetic background only have, I would say, probably 50% concordance in my own population of children in LA. So obviously it's not genetics alone. There is some environmental influence that is remarkable in this disease. Dizygotic twins, siblings, 5%. Offspring of fathers compared to offspring of mothers at much higher risk. And then parents of a child with diabetes also at risk. Relatives account for about 10 to 15% of the cases that we see. Therefore, most of these, particularly children who are going to develop type 1 diabetes, are in the general population with no apparent genetic risk for diabetes. So we've had a number of truly important long-term studies in trying to understand the natural history of type 1 diabetes and how to interdict that process. The first one is called TEDdy, and of course you have to have an acronym for your study, otherwise you can't even get in the literature. And it's looked at a large cohort from pregnancy, even pre-pregnancy, through in uterine life, all the way to about 20 or even more years of age for some of this cohort. Risk factors: exposure to enterovirus, adenovirus, gastrointestinal infections, ubiquitous in childhood. Higher fatty acid levels, increased weight gain. We think about weight gain really only affecting type 2 diabetes, but it does have an effect in the development of type 1 as well. High energy intake, iron intake, and then we can look down and look at protective factors. So early adeno-C infection, vitamin D, vitamin C levels, lots of exposure to omega fatty acids, and also the early introduction of some foods. And in some of the foods, such as gluten exposure, there may be a U-shaped curve where before 3 months is too early, beyond 8 months might be too late as risk factors for the development of type 1 diabetes. So we have learned a lot. Can we put into practice most of this? It's very difficult to put into practice. I think there is a recommendation that has been increasing around vitamin D, but the rest exposures to viruses. What do we need to do for that is perhaps come up with immunizations. So if we look at the development of these antibodies, they begin in very early childhood. You could see by 1 year of age, there is a high percentage of children having the development of antibodies. We can look at, perhaps where these children are from, which cohort they are, either a family member or the general population. And then we can look at, more importantly perhaps, which antibodies show up first and how early these antibodies can be detected. So if we look, the first is the insulin autoantibody, next is GAD, and then we can see that by age 2, there has already been the peaking of the development of these antibodies. There's a secondary recurrence around age 7 or so, 8, and then that sets it up for the peak age of type 1 still being around 12 years of age. So that gets us to another huge NIH trial that has helped us understand this natural history called TrialNet. I was a member of TrialNet for quite some time, and it looked to understand this natural history and then to try to come up with ways to interdict it. TrialNet screened over 250,000 relatives of people with type 1, conducted over 20 intervention, observational, and mechanistic-based trials, and has been instrumental in the FDA approving the first modifying drug for this disorder. Another important and newer trial has been what we call ASK, which is looking to study the development now not just in relatives of people with type 1, but in the general population as well. They've screened almost 30,000 people. You can see a much lower conversion rate. And then of those with multiple autoantibodies, single autoantibodies, and then kind of go through, and at the end, how many of them have been diagnosed already with type 1 diabetes, with diabetic ketoacidosis or without. And one of the goals of this early understanding of this process is to identify particularly children at young age who have antibodies, inform the family of the risk, what the symptoms are, so that we can avoid the onset of diabetic ketoacidosis. And in this cohort, the onset of diabetic ketoacidosis was about 5%, and in the usual population of those who present with type 1 diabetes, it's in excess of 30 to 50%, depending on what study. So we can get into this philosophical thing of why screen in pediatrics. Well, we now have an intervention. It's likely we will have more, so there are also trials looking at different agents. So there actually is quite a good rationale to screen. Screening divides people really into two groups, those likely to get something and those very unlikely to get something. And perhaps with my general pediatrician hat on, I would tell you the most transformative thing in pediatrics in my own career lifetime has been the expansion of newborn screening to pick up early in the newborn period disorders in which we can intervene with a dietary substance or something that's deficient and eradicate perhaps poor overall outcome for an individual. And perhaps congenital hypothyroidism, screening for that is the hallmark of that. If we pick it up before symptoms have developed and begin thyroid hormone, these children have normal neurodevelopment. If we wait for the clinical symptoms, which takes 3 to 4 months or so to develop, we are already impairing neurodevelopment in that individual. So in California, we've had a newborn screening since 1978, and these children are diagnosed immediately within 3 to 4 days, put on hormone replacement, and have normal lives as a result. Post-newborn screening, we don't screen for much in pediatrics. Of course, we do a general physical examination and blood pressure, all those expected issues, but from a laboratory standpoint, we screen only for anemia, lead exposure, and cholesterol. So now coming to that postnatal population, we're not going to screen in the newborn period for type 1. The antibodies aren't there yet, but we're going to screen perhaps somewhere down that line at age 2, that big peak at age 1 and 2. So do we screen at age 2 or 3? Do we screen at age 6 or 7 or 10 or 12? Unclear what the best rationale is. But we know that we do have a screening test that's valid. It's reliable, it's affordable, it has great sensitivity and specificity, and a positive predictive value and low false positives. So the diagnosis and the treatment benefits potentially outweigh the negatives, and as far as cost and savings, they're about balanced, hopefully, as we go forward in time. So the American Diabetes Association recommendations for screening for type 1 diabetes in 2025 is that type 1 diabetes in asymptomatic children with a panel of autoantibodies is currently recommended in the research setting in relatives of patients with type 1 and in those at high genetic risk. I will tell you this is a conservative recommendation. Perhaps by 2026 it will be broader, but right now this is what it is. Persistence of multiple autoantibodies may serve as an indication for then staging an individual to figure out if they are in stage 1, stage 2, or perhaps really converting to frank diabetes. And the reason we want to do this again is to prevent diabetic ketoacidosis. Advanced science and prevention will help lead us to a cure. So expanding the goals of early detection of type 1 diabetes will reduce the risk of DKA. I'll show you the data that supports that. Allow time for the child and the family or the adult themselves to prepare and learn about diabetes and what to look out for. Connect the autoantibody positive individuals to research studies spanning from stage 1, stage 2, and stage 3, and then refer those who are informed of this risk for further follow-up, and particularly psychological support if indicated. So here's the data on the early screening efforts. So if we look at screening programs that have evaluated children less than 2 years of age, and then a more expanded programs evaluating children less than 5 years of age, we can see that maybe the best we can do is around 10 to 15% of those individuals may still show up with diabetic ketoacidosis. But if we look in other registries, and we can see that without the screening, there's a much higher rate. And the Swedish registry, SEARCH, the Finland registry, and the German registry did not screen individuals. They just looked at once the diagnosis was made. TEDdy screened individuals for type 1 diabetes. So we can reduce it perhaps even further as we get more adept in our screening programs, but without screening, we still see a very, very high rate of diabetic ketoacidosis. For those of you who have not taken care of a child with diabetic ketoacidosis or an adult, it's a life-threatening disorder, requires ICU hospitalization, and can actually lead to morbidity as well as mortality. So we are debating on this whole screening program concept of when would we do it? Would it be a single screen at age 2 or 3 or 6 or 10? Is it a multiple screening where you do it and you repeat it in those who are negative? We don't know the answers. There are the ASK studies. There's still the other trials that are going on looking at how to maximize screening as we go forward. But we do know that autoantibodies will be positive in 82% of the time a child who will develop type 1 diabetes by age 15. So if I look at a cohort of individuals who have developed diabetes at age 15 and go back in some of these natural history studies, 82% of them will have had autoantibodies. 79% of the children who test positive for autoantibodies will develop diabetes by age 15, looking at screening at age 2, age 6, and 10. We know adults with autoimmunity are there. LADA is a great example of should we screen at the time of diagnosis in particularly atypical type 2 diabetes, the latent autoimmune diabetes of the adult who's thinner, perhaps doesn't have the other characteristics we usually see with type 2 diabetes, and screen them to be sure that they're not type 1 versus type 2. Should we screen those with GDM and find out whether they actually have a type 1 process or not? And these are researchable questions that are being answered in a number of studies. We do know that the screening is still going on inside TrialNet, so particularly if you have a family member of somebody with type 1 diabetes who's between the age of 2 and 45 and a first-degree relative, they are able to be screened in TrialNet as part of that research endeavor, and for second and third degree relatives between the age of 2 and 20. And the ASK study is screening 1-year-olds and older in the general population. The study is being conducted mainly in the Denver area from the Barbara Davis Center, but satellites are developing, and there's a consideration, should Santa Barbara be one of those satellites to consider screening in the general population. You can screen in your office. You don't have to be part of one of these studies. These are clinical labs with CPT codes, and for the most part, these CPT codes are paid for by insurance if it's justified in your medical note as to, either the first encounter with somebody with diabetes, family history of type 1 diabetes, personal history of autoimmune disease, family history of autoimmune disease, person with health issues in unspecified circumstances. So there's a way to justify screening in your office, and for the most part, having it paid for by the patient's insurance, including Medicare. So one of the things we do know from these studies is that when we do screen somebody, we cause some anxiety. When they are positive, when they're negative, we usually reduce anxiety. There's some anxiety while they're waiting for the results. And when they come back negative, the anxiety is pretty much gone. And when they come back positive, there is a fair amount of anxiety in the child as well as in the family. So it is ethical to have a referral basis. And in all of these large studies, there is a referral to a psychologist to deal with the addressing of that anxiety and to refer for behavioral health when indicated. So if you are going to screen in your office and patients come back positive, this is one of the things to think about. Do you have a referral system to support them through the process? So now we've screened somebody. They have multiple autoantibodies. How do we proceed from there? And the next step is staging. So are they stage 1, fully normal glucose metabolism? Stage 2, where they are in a pre-diabetes state, so the fasting glucose is between 100 and 125. The postprandial or particularly oral glucose tolerance load 2-hour value is between 140 and 199, and the A1C is between 5.7 and 6.4. These are the same numbers used for prediabetes in those at risk for type 2 diabetes. And then stage 3 is the clinical measurements that are compatible with clinical diabetes. So greater than or equal to a fasting glucose of 126, a OGTT greater than 200, and an A1C greater than equal to 6.5. So the next stage after seeing the presence of the autoantibodies is to stage the patient, and that enables us, and some of the staging can actually be done at home. They can send in a finger stick blood sample in the fasting state, as well as after an oral glucose load that is sent to them, and ask in particular, and some of these other studies allow this to be done in the home setting. And this is just showing you that the other thing that people are doing is adding a CGM to the patient for a 2-week wear and looking at the values of that CGM. And of course, this is holding true in the population of individuals who are now getting CGM in the pharmacy for themselves so that they can either train better or eat better, or I don't know what better, but putting on a CGM and looking at in somebody who has normal glucose metabolism, they still have 18% of the time or less with a glucose value of 140 or less. So there is elevation of the glucose in normal individuals, and we don't want to confuse this but we can use a CGM now, and if 18% of the time is greater than 140, then they have stage 2 diabetes. If you get to about 50% of the time greater than 140, you've got likely frank diabetes and meet the clinical criteria. So when we look at all of this, what have we done in these past decades to try to find interventions to either stop somebody from progressing from stage 1, so all they have is autoantibodies and no dysglycemia, stop them from progressing from stage 2 to stage 3 so that they have autoantibodies and prediabetes, or even at the time of the initial diagnosis of diabetes to preserve that beta cell mass to allow for maybe continued exogenous insulin requirements, but at a minimum, and to kind of preserve endogenous insulin secretory dynamics so that that honeymoon period maybe can last forever. So these are some of the agents that have been used. Those in light green had no benefit at all. And I can tell you those in light green were first tested in the animal model, the NOD mouse, and showed effectiveness in the mouse. Matter of fact, we've cured diabetes with over 200 agents in the mouse, and we've only found so far a handful that have been able to be translated to the human condition. So we've looked at oral insulin. We've looked at a number of immune modulators, many of which are used in other autoimmune diseases or in diseases where we're trying to affect a tolerant state. And we can see that in stage 1, in stage 2, and particularly in stage 3, most of these have had no effect. And then we get to that one in that dark, I don't know what color it is, I guess gray. And we get to the 4 in the dark green. And these are agents that have shown to have some effectiveness in stage 2 and stage 3 diabetes. So in stage 2, it means we are delaying the progression from stage 2 to frank diabetes compared to a placebo control. And in stage 3, it means that we have preserved endogenous insulin secretion as measured by the release of C-peptide, which is cleaved off of proinsulin as it's secreted by the normal pancreatic beta cells. So when we get to the only agent now approved by the FDA, it's the anti-CD3 antibody teplizumab, and this has been shown in relatives at risk for type 1 diabetes. So let me walk you a little bit through this trial. So the initial trial had 76 participants, most of whom were children with stage 2 diabetes. So multiple autoantibodies and the preservation of glucose only in the prediabetes state and not high enough to get to the diabetes state. It was a 2-to-1 randomization. It lasted quite a long time. And the time to diagnosis for those treated with teplizumab or Tzield was 2 years versus the placebo group. I'm sorry, it was 4 years compared to the placebo group that was 2 years. So if we look at the difference of those diagnosed, 43% with the active agent and 72% with the placebo. So a change in hazard ratio to 0.41, about half as many patients overall when we look at the annualized rates. Now, there were some, mild side effects as expected. There were some T cell phenotypes that were more common in those who responded. And then there were some endotypes that were more common overall, looking at HLA type, what kind of antibodies were present. So that as we go forward, we will get to the concept of personalized medicine for this, where not everyone with type 1 is going to respond the same to these agents, but there will be endotypes with different HLAs, different antibodies, different ages, perhaps, that will respond in a different way. So when we look at that overall life course of months since randomization and the proportion of those who develop type 1 diabetes, we can look at the blue and see that that's a distinct course, different than the red, which is the placebo. So the teplizumab group, again, had a significant delaying in the onset of type 1 diabetes by about 2 to 3 years. Well, there were some side effects, particularly lymphopenia, as one would expect with an anti-CD3 agent, but it was transient and started to resolve about day 6. So I can tell you, when endocrinologists get in a room with rheumatologists, we are on 2 different planets. What looks like acceptable immune blockade to a rheumatologist looks completely different to an endocrinologist. And we have debated and debated and debated whether any immune blockade is justified in somebody where we have a therapy called insulin. And of course, the answer is, in my opinion, it is justified because insulin does not normalize glucose in the vast majority of our patients, and that's what we need to do to prevent the short and long-term complications of this disease. So here's the extension of the study that was originally reported and ends up with about the same hazard ratio. So 0.45, so half of the half of the difference in the number of patients diagnosed with diabetes. Now, out quite a number of months, 88 months, and we can go through all this, but if you look down at the bottom, the overall median time to diagnosis in the teplizumab group was 59 months, and in the placebo group was 27 months, so that the number progressing is significantly different, about half of those with teplizumab. Then that's great. To find a patient with stage 2 type 1 diabetes requires I had to screen them with antibodies. I have to do an oral glucose tolerance test, fasting glucose or an A1C to stage them. But I don't know how many of those patients there are. I don't know how long stage 2 lasts. I don't know if I tested you today and came back a month from now, whether you still be in stage 2. Maybe you bounce back and forth between stage 1 and stage 2. Where the real bang for the buck is, what can I do in the patient who presents in my office with type 1 diabetes, meeting the clinical criteria from a glucose standpoint, to interdict that process so that they need less insulin, their glucose values are better, their A1C meets target, and they don't have hypo and hyperglycemic emergencies and a marked reduction in the risk over time. So this is looking now at Tzield, and how do we assess in those already diagnosed with diabetes is looking at the release of C-peptide to a mixed meal stimulation. So they drink a can of Boost, you measure C-peptide. C-peptide is there in equimolar to the amount of insulin somebody made on their own, and I don't confuse it with the amount of insulin I'm giving them in an insulin pump or a syringe. So treatment has shown, for the most part in this study that was published in 2023 in New England Journal of Medicine, that stimulated C-peptide difference is significant between a placebo and teplizumab. You can see that at the top of the curve. And as a result, perhaps there's an indication for using this in those already diagnosed. Very short time frame after diagnosis, and obviously this is what we're waiting to find out, hopefully soon from the FDA, whether there'll be an indication. However, there was no difference in the insulin requirements. There was no difference really in the overall glycemia in these patients, despite the fact that they had higher C-peptide levels. So here's looking at, if we look at all the kind of criteria, you could come down. Let me see if I can work this. Here's the peak C-peptide level, and you can see the teplizumab group and the placebo group meeting the criteria for a good release, and there are more in the teplizumab group. But then we can come down and look at the overall glycated hemoglobin and insulin dose, and now we see no difference. Does that mean we should not treat, or does that mean we should treat? I think the answer is we are waiting to finish the research, and the hope is that that preservation of C-peptide alone over time will be significant for the patients, and that we should consider the use in those as well. And if you look at kind of lining everything up, is teplizumab better in a whole number of indications? It is, and therefore, this goes forward in the treatment paradigm for considering. Adverse events, no difference in this population, nothing really significant, most transient, and resolved by the end of the study. And here's a recent report looking then at what can I see from a CGM? Is there anything different maybe in the overall glycemia? I don't see it maybe in the A1C yet. I don't see it in the amount of insulin somebody requires. But here's now looking at 6.2% higher time in range, which is significant. Mean glucose lower, which likely is significant. Fewer minutes above 180 and fewer minutes above 250, which is a significant improvement in overall glycemia. And as time went on, some reduction in insulin use, and therefore, we need to continue to study and get data on these patients. Just to focus on something different, this is looking at, should we consider some of these viruses that we've learned from the TEDdy trial as being exposures that may be significant in inducing the diabetogenic process? Here's enterovirus, looking at a meta-analysis of RNA and proteins for enterovirus in type 1 individuals or in those with autoimmunity. A large number of publications, many met the criteria, and the overall conceptualization that there is a rationale to develop vaccines targeting diabetogenic enteroviruses for type 1 in early life for children. And that would be something that hopefully can continue to go forward, of not only trying to interdict with agents in the patient themselves once they've got autoimmunity, but trying to prevent that autoimmunity from the beginning, understanding what some of the exposures truly are. So that gets us to Italy. I really want to go to Italy this summer, but I don't think I'm going to make it. And why do I want to go? Because they've passed a national law stating that children in Italy should be screened across the board for type 1 diabetes as well as celiac disease. They haven't started it. They still don't know which autoantibodies they'll test for. Will they do any genetic testing for HLA typing? At what age, at what intervals? What will be the overall approach from a psychological standpoint and education program? And it's unclear what happens next, but they did take a bold step to suggest that this should be on the agenda going forward for individuals in Italy. So kind of went through a lot. The burden of type 1 diabetes, we've made incredible strides, but it is a burden as far as this being a significant childhood and adult illness. And of course, not to forget the number of those diagnosed with type 1 in adulthood. Still less than optimal glycemia, significant disparities, and personally spent a fair amount of my own career working on that, which is incredibly important. The natural history we now understand quite well. We've learned a tremendous amount by these long-term NIH-funded studies. The reasons for screening, I hope, are understandable to you: to prevent diabetic ketoacidosis, to protect the beta cell, and to allow for improved, if not normalized, beta cell function. We've got the first agent that should embolden all of us to continue to work further, to effectuate not only in those who are relatives, but understand what we can do in the general population as well. And will other countries follow Italy? Or I don't know, but at least go there. So I just want to end that. SDRI, the Sansom Diabetes Research Institute, has done throughout the decades research on the population of those who live in Santa Barbara and the surrounding areas. We've got Alex here, who can help get your patients, if you have them, into appropriate research studies around type 1 diabetes so that we can continue to learn and advance interdictions and therapies. So right now, they're looking at using inhaled insulin in gestational diabetes, and also the use of GLP in those with type 1 diabetes to expand whether it will have a significant glycemic benefit and perhaps help preserve beta cell function as a result of that. So I will end here, and I don't know if I have time for questions or not. I think I finished right on time. Any questions?
Thank you for that talk. It was excellent. I don't totally understand the issue with 1 week of transient leukopenia and the rheumatologist. Like, can you explain that? Like, is it they pretend this is an actual problem?
No. We endocrinologists pretend.
The other side.
Yeah, no. Rheumatologists use this stuff like it's water. And all the other immune, and endocrinologists, you talk about any immune blocker and they just have like a panic attack. Yes?
Have there been any thoughts of trials in these patients with risk factors for new onset type 1 diabetes using a low carbohydrate diet to try to reduce the or delay the onset of type 1 diabetes?
So in that TEDdy trial that looked at those thousands of patients over time, there's no doubt that weight gain is a risk factor, and diet and activity, so physical activity. Not alone in those trials that are looking at at-risk individuals, but as part of the paradigm of, I'm going to do an intervention or not. They're trying to monitor physical activity, monitor diets to try to understand the additive or subtractive effect of those as well. There's obviously a big desire to help the pediatric population in particular maintain healthy weight. That gets into type 2 diabetes in youth, which is, when I started my career, we had like 2 in the clinic, and every time they'd come in, everybody would run around and go, oh, and then run out and go, oh. And now 25% of our patients have type 2 diabetes. Yes?
In regard to the application of TDD, newly diagnosed type 1 patient, considering that the C-peptide increases, so one expects to have like a prolonged honeymoon period. And that should indeed interpret as a less insulin. So we are not seeing this. Then that brings me to the question that how we can convince our patient to, take the TZ, all the, side effects and everything, and not expect to include if that's right.
Well, yeah, I think that original study was, not long enough to really see some of the effects, and the prolonged phase of the study is showing a little bit more benefit. But right now, that using TZIL on stage 3 at the time of diagnosis is not approved. I mean, it's only approved for stage 2, but hopefully will come to stage 3 soon. And I think, as far as talking to the families at that point, particularly in the pediatric population, it will make more sense that, give me something to make this disease better or modified or, less risky over time. And I think that's where, the real, and not only that, you've already found them, right? And they're obviously highly motivated to do whatever they can, I think, for the most part. It's a little trickier in those who are completely still asymptomatic, I think in convincing some of them to go into a trial or into a therapy. But it turns out there's been tremendous interest across the country in the pediatric endocrine clinics to using TZIL. The providers are interested, the patients are interested, even in stage 2. Well, thank you.